The second group of mental disorders or cognitive disorders that we are going to talk about are mood, cognitive, and eating disorders. So lots of interesting mental disorders out there. Same learning objectives from the last section. Mood disorders are disturbances in emotions that can cause subjective discomfort or impair a person's ability to function. They do have a tendency to run in families. There is a biogenic cause. The neurotransmitters norepinephrine and serotonin are affected. If there's too much activity at the synapses, that results in mania. And we'll talk about what that is. Too little activity results in depression. So the two types that we're going to talk about are depression and bipolar disorders. So factors in mood disorders include genetic, developmental, and psychosocial stressors. So obviously multifactorial. So depression, it we're going to talk about the affective presentation, like what people appear like or what they feel like, and their cognitive presentation. So the affective presentation is sadness, dejection, prolonged mourning, feelings of worthlessness, anhedonia, which is the loss of joy of living, or so like just nothing excites you. It's just dull. The cognitive presentation is pessimism, disinterest, especially disinterest in activities that you were formerly interested in, decreased energy, loss of motivation, self-denigration, and low speech volume. So that's the depression end of it. Um, Bipolar disorder, they're different. So the classic presentation, they used to call it manic depression, and that's the cyclothymia, cycling between depression and mania. Now they have different categorizations, bipolar 1, bipolar 2, and cyclothymia. So bipolar 1 is, I sort of think of it as, if you think of cyclothymia as being ranging from mania to depression, bipolar 1 is sort of like ranging from mania to normal. And bipolar 2 is ranging from normal to depressive. And cyclothymia is the whole range. Hopefully that makes sense. That's how it works in my brain anyway. So bipolar 1 is usually diagnosed by having one or more manic episodes. And so the affective presentation is elation or irritability or impulsivity, grandiosity, decreased sleep, exaggeration, boundless energy, uninhibited verbally and sexually, and sometimes even uninhibited in the way people dress. When there are people who cycle between manic and other phases, sometimes when they're in a manic phase, they dress really flamboyantly, really brightly. People in the manic phase will go out and buy a bunch of stuff. And then maybe when they're out of the manic phase, they'll sell it all. Or, so the grandiosity a lot of times, like wanting to be connected with famous people, wanting to be connected with celebrities, or even sometimes saying that they're connected with those famous people. So interesting. So that's the bipolar 1 is like the mania side of it. The cognitive presentation of mania is accelerated and pressured speech, tangential content, where someone goes from one subject to another, even though I do that, maybe not in a manic way, but one subject to another really quickly, and disjointed thoughts and speech. So the interesting thing is my nurse peeps in the emergency department tell me that when somebody comes in a manic episode, what they do is give them medications to calm them down. They give them anti-mania medications. So when they come in a depressive episode, they don't necessarily give them medications to bring them up, but that mania is something that can really be disruptive to someone's life. I worked with someone who had a bipolar disorder at one point, and he was okay when he was on his medications, but he would frequently voluntarily go off of his medications. And he told me one time in a session, he said, when he's in that mania phase, he feels like he's closer to God. And so he didn't want to take his medication and lose that. So I thought that was really interesting. But also, he would come in when he was in a manic phase, and he would come into the clinic. And that clinic, we had like a phone in the lobby that patients could use. This was before cell phones. Patients could use to call their ride or to, whatever. Well, he'd get on the phone and be yelling at people and, really kind of making a scene. He'd yell at the front desk, he'd get all crazy, and then I would get him back to the gym, and he would be really loudly expounding on many subjects. And as you can imagine, it was very difficult to get him to focus on what he needed to be doing to treat his physical problem. So he was obviously coming into PT for a physical problem, but he didn't leave his bipolar disorder at home. So it was kind of difficult to deal with. And very, very interesting. He did get better physically, and he did, recover from his surgery and do well with his therapy goals. So that is a good thing. Sometimes I've worked with people with bipolar disorders who they don't like to be in a closed room. So they don't want to be in a treatment room with the door closed. The one person told me they prefer either like a curtained room if they need privacy, or to be out in the gym so they don't feel enclosed and trapped in. So that could be helpful for keeping people focused during a therapy session. Bipolar 2, sort of like I said, it goes from the middle down to depressive. And then cyclothymia is cycling between depression and mania. And so they're all treated with similar medications. And it is very interesting to work with people. And I always like to hear what people are going through and um, try to meet them where they are. It's not always easy. Sometimes they're in a place that you just can't go. So, mood disorders are generally treated pharmacologically with antidepressant drugs or anti-mania drugs if applicable. Electroconvulsive therapy has also been found to be effective for treatment of um, mood disorders. So, interesting, right? Schizophrenia is an interesting disorder as well. It's disorders of thought or cognition and severely impaired cognitive processes to the point of personality disintegration and social withdrawal. So they group symptoms as being positive or negative. So the positive symptoms are delusions or bizarre behavior. The negative symptoms are very flat emotions and decreased speech. So you can sort of see the positive and negative of that. General symptoms include disorganized thought processes, impaired communication with inadequate language skills, and delusions or false beliefs and ideas. People with schizophrenia generally have a tough time holding down a job, as you can imagine. That would be kind of difficult to deal with. And so a lot of times they are either in a care facility or a group home of some type where they have people help them deal with kind of the day-to-day things that they need to deal with. The symptoms, delusions are a big symptom of schizophrenia. Delusions are false personal beliefs, firmly held, consistently held despite evidence or logic. So you cannot talk someone with schizophrenia out of their delusions. So delusions of grandeur, delusions of control, delusion of thought broadcasting, interesting, delusion of persecution or paranoia, um, or delusion of reference, where you're just not connecting the dots. Um, Hallucinations are common symptoms of schizophrenia. So hallucinations are sensory perceptions that are not directly attributable to environmental stimuli, like olfactory, visual, and auditory hallucinations. There are some medications that treat other disorders that also cause hallucinations. So, I had one person tell me after their total knee replacement, they were on whatever pain medications they were on in the hospital, and thought that their mother was sitting in the chair beside the bed. Well, this person was in their 80s. I don't think their mother was probably there, but um, and they said it was the weirdest thing ever. And once they went off the medications, they went away, so that's good. With schizophrenia, there are often speech disorganization or thought disturbances, tangential speech, and loosening of associations. Um, there's also a problem with motor activity, disorganized motor activity. So extreme activity levels, either high levels of activity or low levels to the point of catatonia, where the person's just not moving. So schizophrenia is a pretty extreme disorder. So the etiology of schizophrenia is interesting. There are a variety of syndromes that tend to be different in each individual, but common changes include reduced gray matter in the temporal lobes, enlarged third and lateral ventricles, abnormal cells in the hippocampus. And the hippocampus is a place where a lot of our memories are integrated, so that's interesting. Excessive dopamine secretion and decreased blood flow to the frontal lobes. And the frontal lobes is where our personality and executive functioning happen. So very interesting that those are common in schizophrenia. The theories of the etiology include that maybe you have a genetic predisposition to it, or there's some sort of brain damage in the fetal stage when you're developing. So the dopamine secretion, it's a very interesting thing. Dopamine is involved in a lot of different disorders. It's involved in ADHD, it's involved in schizophrenia, it's involved in Parkinson's, and it's the opposite. It's lack of dopamine rather than excessive dopamine. And actually have worked with one individual in the area of Parkinson's who having schizophrenia for their life, later in life developed Parkinson's. So very interesting. But it all has to do with dopamine, and maybe their excessive dopamine secretion over a lifetime developed into low dopamine, which caused the Parkinson's symptoms. But it's really interesting, but clearly there are physical changes in the brain that are causing the problem. So it's usually treated with antipsychotic drugs, neuroleptics. The antipsychotic drugs, unfortunately, frequently cause side effects that are related to excessive extrapyramidal activity. Those can cause those Parkinson's-like symptoms as well. People who have extrapyramidal strokes can have those type of symptoms too. Involuntary muscle spasms in the face can be a side effect. Um, and also in the neck, arm, or legs, kind of dystonia, so dysfunctional tone, muscle tone, chewing or grimacing, repetitive, jerky, or writhing movements, which is called tardive dyskinesia. Some side effects may be reduced using anti-Parkinson agents. So there's, like I said, there's some kind of connection between, I mean, obviously not everybody who has Parkinson's has schizophrenia, and not everybody who has schizophrenia has Parkinson's, but there's a connection in there somewhere. In the neurochemical, there's a neurochemical connection. So psychotherapy and psychosocial rehabilitation are also used in schizophrenia treatment. And that's where I was saying that a lot of times people live in a healthcare setting or a care setting, so they can get the kind of treatment that they need. Cognitive disorders are disorders of thinking processes, memory, perception due to either transient or permanent brain dysfunction. So we're going to differentiate between dementia and delirium, and then brain trauma or organic brain syndrome. So dementia is like Alzheimer's. There's some kind of permanent brain dysfunction, and it's usually progressive, getting worse over time. Delirium is usually a transient cognitive disorder caused by trauma or medications or a combination of the two. And the difference between dementia and delirium is delirium goes away when you remove the cause. Dementia does not go away. Brain trauma can cause organic brain syndrome, where there's actually damage to the brain that's affecting cognitive processes. So, the pharmacology used to treat cognitive disorders, antidepressants, are commonly used, and condition-specific medications. So there are some medications that are specific for Alzheimer's or specific for other types of dementia. So dementia as a whole, it's a decrease in cognitive function that's characterized by the three A's. Aphasia, which is disturbance of language. So like you can't remember words, or you can't remember the names of things, or you can't remember people's names. Apraxia, which is inability to carry out a motor activity. And if apraxia is you can't carry out the motor activity even though you still have the ability to do it, you just can't organize it in your motor cortex. Agnosia is the inability to recognize objects or people. So that's where the person with dementia doesn't recognize their family or their home or something like that. So Alzheimer's disease can cause dementia, vascular disease can cause dementia, normal pressure hydrocephalus, which is we'll talk more about in neuro, but there's some kind of fluid buildup in the brain, and it's causing trauma basically to the neurons, and that's causing dementia. Advanced Parkinson's disease, there is a brand of dementia. There's a type of dementia that's associated with advanced Parkinson's disease, and they call it Parkinson's dementia. Delirium, on the other hand, is it's more transient. It's usually caused by medical conditions. It can be caused by substance abuse or an adverse drug reaction. Um, it's an impairment in consciousness. You have reduced ability to focus or sustain or shift attention. So, you know how in acute care class we said people are alert and oriented times three or something like that. They're alert, they're oriented to person, place, and time. With delirium, a lot of times they're disoriented. They can't focus or shift their attention, but then it goes away. That's the thing about deliria versus dementia, is once the medical condition is resolved or the drug gets out of your system, then the delirium resolves and it goes away, which is good. So, organic brain syndrome can be a short-term or lasting cognitive deficit as a direct result of trauma to the brain. So, if sometimes people have a concussion or some contusion or laceration to the brain from a trauma, and it causes them confusion or memory loss or irritability and agitation or poor concentration and attention deficits. So, if you've ever worked with somebody right after a concussion, sometimes they don't remember 5 minutes ago. And it's scary if they're your loved ones. It's not that exciting if they're your patients either, but um, sometimes that resolves and sometimes it doesn't. With a mild concussion, a lot of times it resolves, but it is scary when it happens. So eating disorders, it's behavior that's characterized by physically or psychologically harmful eating patterns. So, anorexia nervosa. So we talked about anorexia as a symptom for a lot of other things, and anorexia just meaning lack of appetite. But anorexia nervosa is the eating disorder type of anorexia. And bulimia nervosa is another type, and we'll talk about them specifically. So eating disorders are generally treated in inpatient treatment centers, and they're treated with nutrition and nutrition therapy and antidepressants and psychotherapy. So anorexia nervosa usually involves an intense fear of becoming fat and engagement in self-starvation and the inability to objectively assess your own physical condition. So it's called body dysmorphia. So someone with anorexia might be really thin and they look at themselves in the mirror and they go, no, fat. And it's not one of those fat mirrors that just makes you look fat. So the physical complications of anorexia nervosa include cardiac issues and hypotension, which you can, because of electrolyte imbalances, when potassium gets too high or too low, you can develop cardiac arrhythmias. And typically if people die from anorexia nervosa, that is the thing that gets them, is those cardiac arrhythmias. It can cause bradycardia, which is a low heart rate, and hypotension, which is low blood pressure. The types of anorexia nervosa are classified as restricting, meaning people who just don't eat, and binge purge, where you eat the food and then throw it back up or something like that. There are psychiatric complications, guilt, depression, anxiety. So, it's not a nice thing. Hopefully they can get help um, before it gets to the point of cardiac arrhythmias. Bulimia nervosa involves binge eating. So, binge eating at least 2 times per week over 3 months. It's a loss of control over eating or using inappropriate means to control weight, like laxatives, vomiting, exercising to excess, sometimes is called exercise bulimia. So like saying, oh, I ate that pizza and now I got to run 15 miles on the treadmill, or something like that. And fasting, after you binged, then you fast. The physical complications, particularly with vomiting, are erosion of tooth enamel because you're vomiting up stomach acids, esophagitis, irritation of the inflammation of the esophagus, and decreased potassium. So there's again the risk of cardiac arrhythmias and cardiac arrest. So the eating disorders um, can kill you basically. So never a good thing.